But hopefully I'll impart some of my wisdom on CT scans and MRI scans for sinuses, on particularly radiological features that you need to be aware of in respect to sinus surgery. Right, couple of slides, here we go. So I'll go through some of the key anatomical features and also look at some anomalies. I'll give you the systematic approach that I use for looking at preoperative CT scans that I expect all the trainees to use when we're in theatre, and give you some examples of some sinusal pathology. So what I thought I'd do is start with is we're interested in radiological anatomy from scans to kind of put that into perspective with our endoscopic work, particularly when we're doing endoscopic sinus surgery. So I guess as a starting point, and you can use the chat function here, let's have a think about what the anatomy is here. So if you want to stick in the chat the letters of any of those structures you think you can see on the picture on the right there, this is the right side of the nose, if you're not sure. So we've got A, B, C, and D. Any other takers? F and I, yeah. Okay, well, I guess the only one that you can't see on that image is the G, the middle turbinate basal lamella, because it's tucked away behind the ethmoid bulla, right back here. Pretty much all the others you can identify there or some part of. So in order to sort of think about how we apply our radiological anatomy to our endoscopic anatomy, we need to obviously look at our CT scans. So these are our predominant sort of focus when we're undertaking sinus surgery. So here's a coronal section of the sinuses, and there's a few things labeled on here. So again, maybe using the chat, you can write down anything that you can think is clearly labeled on that coronal section. Some of the clues are in the lettering there. Particular brownie points if you get the asterisks. So what have we got? We've got M is middle turbinate. Eduardo Prades gets the prize for the halocell. Infraorbital Alexander as well. Yeah. Okay. Good. Good. Excellent. Right. Good. Oh, I think you're identifying some of those structures. That's excellent. So let's get on to the next slide. So yeah. So we can see that B is the bulla, M middle turbinate, inferior turbinate. This arrow is actually pointing into the ethmoid infundibulum, and this arrow here is pointing to the maxillary sinus ostium. And note that that's laterally placed in that space. And those that got the asterisks being the infraorbital ethmoid cell or the halocell are correct. Okay, so come on slides. Who is this chap? Very important person. Any takers? Messerklinger, excellent. Messerklinger. So he was the godfather of endoscopic sinus surgery. So he is the guy that basically took the Hopkins rod, as you can see him doing there, and demonstrated a way of trying to access the sinuses in a physiologically sound manner. And he wasn't a great English speaker, but his disciple Heinz Stamberger was a great English speaker, and it was Heinz Stamberger that did a lot of the work to spread his gospel to the ENT community. And he defined some key landmarks now. Which of the following do you think are important endoscopic landmarks when we're doing sinus surgery?
I'll launch a poll so that we can vote.
Ah, perfect. Okay, that's good. So which of the following important landmarks? Basal lamella, nasal septum, lamina papyracea, face of the sphenoid. Okay, and the results are in. So actually the two right answers on this were basal lamella and face of the sphenoid, A and D. So interesting that a few more of you went for the middle two. And I mean, obviously those are landmarks that you see on the nose, but this is in terms of endoscopic surgery and our dissection from anterior to posterior. Okay, so yeah, so Messerklinger defined four consistent landmarks. So the four we actually defined were the uncinate process, the anterior face of the bulla, the middle turbinate basal lamella, and the face of the sphenoid. And then he also described three inconsistent landmarks, which are the back wall of the bulla and the superior and supreme turbinate basal lamellae. And for those who didn't know, there was such a thing as supreme turbinate. Now you do. It doesn't exist in everyone, but you do find it from time to time. So let's put that into perspective. So this is a sagittal sequence, and this is what you might see in a CT scan, be able to identify these landmarks. So we can click on here and we get, there's our front one, the uncinate process. Then we've got the anterior wall of the bulla, middle turbinate basal lamella, and face of the sphenoid. And those things are going to be constants. And so we can often identify those through our sagittal CT scans. So the next thing we want to think about is the uncinate process, and that can attach in one of three ways to the either lateral wall or the skull base. And there's a sort of reason that that's important, because it affects the drainage of the frontal sinus. So if I show you diagrammatically, so a type A attachment is where the uncinate process attaches to the lamina papillaceus, to the orbit essentially. A type B attaches upwards to the skull base, and a type C attaches to the middle turbinate. And we can see that if you've got a type B or a C, the outflow of the frontal sinus will join that of the maxillary sinus in the ethmoid infundibulum. So they have a sort of shared drainage pathway effectively. Whereas in a type A situation where the lamina papillaceus, sorry, the uncinate is attaching to the lamina and creating what we call the recessus terminalis, you've actually got a sort of slightly separate outflow. And that becomes pathophysiologically important, because you can see, particularly if you get an odontogenic sinusitis that's originating in the maxillary sinus, that if you've got a type A attachment of the uncinate, then that pathology will confine to the maxillary sinus. Whereas if it's a type B or a C, that pathology can spread and involve the frontal sinus and also the anterior ethmoids. So the next thing to think about radiologically is the osteomeatal complex, and that's basically the term given to this space defined between the orbit and the middle turbinate that includes the uncinate process, the ethmoid bulla, and the ethmoid infundibulum. So it's a three-dimensional space. It's the final common pathway for the maxillary, frontal, and anterior ethmoid sinuses. And because of that, obviously, pathology in that area can have a direct impact on those sinuses in a retrograde fashion. So the ethmoid infundibulum I mentioned before. For those of you that are Latin scholars, you may recognize that infundere is to pour into, and then it's basically describing, because it's a funnel-shaped space. So the funnel starts at the maxillary sinus ostium and ends at the end of the free end of the uncinate process inside the nose. And that's the place where you normally stick your backbiter in when you start doing sinus surgery. Around the ethmoid bulla, you get these spaces. So you get a suprabulla recess, which is a space above it. Doesn't always exist, but if it is there, it sits in that pocket above the bulla. And you might also get a retrobulla recess, which is a space behind the bulla, and you'll identify this on a axial CT scan. So you can see these structures identified here. So you can see the middle turbinate there, the uncinate process, and the bulla, and you can see the spaces. The next thing that you want to be interested to look at on your CT scans is the ethmoid roof configuration, and this was described by Kiros, who originally described three classifications, and then a fourth one's been added, and they really just reflect the depth of the olfactory fossa. And so to show you the different variations of that, so a type A is the best one you want to see, and that's because this little bit of bone here, which is what we call the lateral cribriform plate lamella, LCPL, which is the thinnest part of the cribriform plate, is its shortest distance. So this is obviously, from a surgical point of view, a favourable situation because you're less likely to injure this and cause a CSF leak. Obviously, the longer this little bit of bone gets, the more chance you have of causing an injury here when you're working in the ethmoids. However, the most risky configuration is this type D situation where you've got a slanting lateral cribriform plate lamella. And that means that not only is it running across the sort of superior aspect of where you're working, but it's also that there's a longer exposure of that area. So that's basically something that you really want to kind of keep an eye out for when you're looking at the scans. That's there. So it's really this the depth of this space between the orbital process of the frontal bone here, which is the ethmoid roof, and the top part of the cribriform plate. Oh, sorry, those arrows have moved slightly there. And of course, as I've pointed out, obviously failure to recognise the adverse anatomy in this area can lead to this sort of thing happening during sinus surgery, which is kind of not the thing that you want to see come out of an operation if you can help it. So what else? One of the other things you really want to kind of identify on your preoperative scan is the anterior ethmoid artery. And this was described by David Kennedy as the nipple sign. So I always ask my trainees to look out for Kennedy's nipple. And that's simply because it's this kind of protrusion here at the side of the orbit. And as you scroll backwards through the coronal sequence of the CT scans, you'll see this kind of point come to light here usually on both sides. Now this situation here, you can see that this happens below the skull base. So there is air above and below the anterior ethmoid artery. So it's in a little bony mesentery. Now when you see this, it means it's much more exposed to injury with your through biting forceps. But a lot of the time you'll find that the artery sits quite nicely along the skull base. And so you shouldn't have to worry about that in that circumstance. But be mindful of where it is, of course. The key example when you find that the anterior ethmoid artery is exposed is typically when you find there are supraorbital ethmoid cells, and we'll come on to what those look like in a few moments. So moving towards the back of the nose, the space of the spheno-ethmoidal recess is an important area to consider if we're approaching the sphenoid sinus. It's the natural drainage pathway for the sphenoid ostium, and it's basically bounded by the septum, the superior turbinate from a medial to lateral perspective, but there's no definitive anterior border. I guess you could sort of consider that it starts at the front of the middle turbinate, and as you go alongside the middle turbinate, alongside this between the middle turbinate and the septum, it's that line here along to the sphenoid ostium. So to think really about how you approach the sphenoid sinus, it's important to look at the superior turbinate on the preoperative CT scans. My colleagues in Vancouver did a little study a few years back where they looked at a series of CT scans and actually kind of classified the attachment of the middle turbinate, sorry, the superior turbinate, as to where it attached to the face of the sphenoid. And they showed that nearly 80% attached either in the medial or the middle third of the face of the sphenoid, with about 20% on the lateral third, and a very few attaching to the orbit. So how that looks, well, if you divide up the face of the sphenoid into thirds, like so, then you can see in this example here, the superior turbinate attachment is here, and you've got the sphenoid ostium here. So in this circumstance, coming back alongside the septum with your endoscope and your instruments to approach the sphenoid, it lends itself to a transnasal approach. Here you've got a type B attachment, and you can see this is in the middle third here, with actually quite a wide space here. So again, you probably favour a transnasal approach here. And in this example here, we can see that the attachment is further out. In this circumstance, sometimes you may find that the superior tegument actually almost curls round in front of the face of the sphenoid before it attaches. And this may, I mean, you still may find that a transnasal approach is possible, but it also means if you're thinking about trans-ethmoidal approach that you may want to employ an approach that comes through the superior turbinates and the lateral ostium. And that's a type D where you can see the superior turbinate is attaching right out onto the orbit here. So moving towards the frontal sinus, thinking about some of the anatomy there. The frontal recess is a key bit of anatomy to look at on the CT scan. And I find particularly useful the sagittal section that you can see here, because that helps to define two key bits of anatomy, the Agonasi cell, which can vary significantly in size, and that defines the anterior border of the frontal recess. And then at the back, you've got the attachment of the ethmoid bulla, what we call the bulla lamella, to the skull base, and it does so where the anterior ethmoid artery crosses the skull base. And that really defines the back of your, or the end of your frontal recess. Now, there are a huge range of variations that you can see in the frontal recess, and we'll just run through a number of examples of these now. So we mentioned the Agonasi. The Agonasi you will see on your coronal sequence as you scroll from front to back. It's usually the first cell that comes into view, and you'll often see it just before you start to see the front of the middle turbinate. So there's this circular structure here, and it can be quite well defined, but very occasionally it can be almost negligible. And in fact, a case I did only last week, there was no real Agonasi to see, and when we did the case, likewise, there was just nothing really to remove in that area. So it is occasionally missing, probably missing about 5% of cases. So it's an important structure to remove because, as you can see, as an example where it's left behind, not removing it properly may lead to sort of continued obstruction of the outflow of the frontal sinus. And there you can see it nicely. So Stamberger described this as the removing the egg and uncapping the egg, sorry, was the phrase he used. So this is the sort of the eggshell upturned that you need to uncap. So the next thing to consider is the supraorbital ethmoid cell. And when I'm talking to trainees about recognizing things on scan, it's a case of say what you see. A supraorbital ethmoid cell does what it says on the tin. It's a cell that extends over the orbit from the ethmoids. And they can be commonly mistaken for the frontal sinus, particularly in some cases. As this example shows, they can actually be bigger than the frontal sinus themselves. So here we've got the left frontal sinus, and here we've got a supraorbital ethmoid cell. So they can be quite extensive in size. And when you see this sort of picture on a coronal sequence where you see this kind of slot going across the top of the orbit, this is very characteristic of a supraorbital ethmoid cell. So you see this kind of space. And so again, it's recognizing that this may affect your approach to the frontal sinus, but also may increase your concern about injuring the anterior ethmoid artery. So then we've got the frontal cells. Now, there was a recent, well, I say recent document, it was published about 4 or 5 years ago now, the anatomy of the sinuses in the European position paper. And they did look to sort of redefine some of this, but unfortunately, those of us that kind of learned our anatomy and terminology before that came into being a little bit maybe perhaps stuck in our ways. And so I did my fellowship in Vancouver, and my boss trained with Fred Kuhn, and Fred Kuhn was the guy that invented this frontal cell classification. So it's very much ingrained in my psyche to know this. But what he described was the type 1 to 4 frontal cells, and what I'll do is talk you through those. So a type 1 is where you've got a single cell above the Agonasi. So here's your Agonasi cell, and you've got a single cell above it, and you can see that on both sides here. A type 2 is where you've got your Agonasi, and then you've got 1, 2 or more cells above the Agonasi cell. And a type 3, you've got the Agonasi cell, and then you've got a cell above it that extends beyond the frontal os into the sinus itself, and it can sometimes almost fill the sinus outline and you have to really look carefully to identify that, because you may actually get a cell within a cell almost of the thing growing within the sinus. And then he also described a type 4 frontal cell. Now, I was taught to believe that this was a kind of myth because when this terminology was invented, CT scans were in their infancy and the cuts were thick cuts, and therefore someone was just missing where it connected to the frontal recess. However, I had this case about 3-4 years ago, and I'm pretty convinced this was a separate cell on its own that was not itself connected directly to the frontal recess. So I think there are occasional circumstances where you may find an isolated cell tucked away in the frontal sinus. The next variation you might see is the intersinus septal cell, and that's a cell within the septation between the two frontal sinuses, as the name suggests, and it will have to drain either to the left or the right. And so your job when you look at the scan on the coronal and the axial sequences is to work out which side it's going to drain into, so that you know when you grain endoscopically, when you look up, which side to expect to see that extra opening. And you can see on this example, this is a one that's draining to the right-hand side. So you can see the frontal sinus drainage here and the intersinus cell coming here, and you've got a little septation between the two. Here's another example here. So this is important to recognize this, particularly if it's in a pacified area when you're dealing with the frontal sinus. I think that's another example there. So I'll just go through a few anomalies now. So concha bullosa is one that you may have seen. So this again probably affects about sort of 5% of cases that I would see in a year. So you've got pneumatization in the middle turbinate, and you'll see that typically on a CT scan as this kind of nice airspace within the middle of the middle turbinate. And so when you think again about your surgical approach, you just want to kind of be mindful that you may need to kind of deal with that in order to access the sinuses. So for here, you've got maxillary sinus pathology. You want to remove this lateral half of the concha to access the sinus properly. There we are. So this is the next one, which is the infraorbital ethmoid cell, and this is where you've got a pneumatization of the cell underneath the orbit, which we saw on the earlier sequence. These can be variable in size. And again, you can see here, this is actually affecting the outflow of the maxillary sinus. So it's important to recognize and deal with as part of the procedure. Yeah, sometimes, again, these can be quite extensive. This one here you can see is, half the size of the maxillary sinus. So they can be quite big on occasion, but they're usually kind of a small cell underneath the floor of the orbit. And then the next one is the Spheno-Ethmoidal cell. It's also known as the Anodi cell. And this is a cell that pneumatizes laterally and superiorly over the sphenoid sinus from the posterior ethmoids. And the reason it's really important is because it can lead to exposure of the optic nerve. And if you don't recognize it, you may, of course, therefore injure the optic nerve in the back of that cell. So you can see this is an axial view of how it would potentially pneumatize over the optic nerve. So it's very important to identify that both on the axial but also on the coronal sequence. So you can see here's an example here. So you've got the sphenoid below, and you've got this pneumatization of the posterior ethmoids going over the top of the sphenoid. So I said I'd talk you through my systematic approach to the CT scan. So this was something we published in Clinical Otolaryngology, I think back in about 2013-14. And so this basically just gives us a significant score to all of those things that I've just talked through. And it's just useful, even if nothing else, to have as a checklist. So you can sort of, sit with this list in front of your scan at the start of the operation and work down and think about all these things and whether they're present. And the significant score is there really just to sort of, give a degree of complexity, how that might add. So the complexity of the procedure might add to the amount of time that you're going to take for the procedure as well. So this is the things that you'll see on the coronal sequence predominantly. So looking through the different frontal sinus anatomy, appreciating any deviation of the septum, the anterior ethmoid artery, the attachment of the uncinate, the presence of any pneumatization of the concha, any Haller cells. Important to also identify whether the maxillary sinus is hyperplastic, because that may also have an effect on where the lamina sits relative to it. and will avoid you unnecessarily injuring the lamina papriosa. The bulla, the cribriform plate, and also any dehiscence of the lamina, particularly if you're talking about a revision case, any gaps in the lamina that have been caused on a previous operation are important to identify. On the axial and sagittal sequences, again, you can look at the presence of the Anodi cell. We talked about the superior turbinate attachment. Also important to identify the sphenoid intersinus septum, because that can attach laterally over the carotid artery. And you may also detect dehiscence of the carotid artery in the back of the sphenoid. And then the other thing I look at, particularly in the sagittal view, is the width of the frontal recess and the slope of the skull base. Sometimes the skull base may run parallel to the floor of the nose. Other times it may be more angled. Sometimes it goes along sort of fairly flat and then goes up quite steeply in the frontal recess. And these are all things that will just help your appreciation of what to expect when you start operating. Now, before I go into this bit here, I know that you've had some stuff transferred onto the system, Hattie, hadn't you? I don't know if you've got, is there an easy way to flick onto that, or is it better to just go through my slides?
So Dr. Puara hopefully will be able to share with us the scans.
Hopefully if we get access to that, this is a recent case that I thought would be quite a nice illustration of some anatomy. Shall I stop sharing? Is that the best thing?
I need to, I'll have to stop sharing and share my screen. So I've got your axial post-contrast and sagittal post-contrast views. I don't know what other views you wanted to have a look at. I've only got the MRI.
Oh, you've got the MRI. Okay. So well, I'll give a little potted history on this one. So this was a gentleman that was referred to our clinic with a 4-month history of discharge over his right eye. So I don't know if we can scroll the sagittal sequence there just to identify the sort of anterior border of the right frontal sinus. Now, his history was that in 2018 he'd had an external approach to a right frontal mucocele through a supraorbital lid incision, so an incision through the crease of the upper lid, and that had drained the mucocele. But he'd been sent over to me having had this discharge over the eye, and his CT scan had identified apparent recurrence of the mucocele. And it also identified that there was a dehiscence of the posterior table of the frontal sinus as well. So he had basically a gap at the front and the back of the frontal sinus. Now, what I was interested with this MRI scan was obviously just to work out whether there's any involvement of the dura before proceeding to any surgery. But I think you may also be able to identify that there's the actual sort of presence of a fistula there. I think just actually below the line there, can't you? So what looked to have happened in this case was that what hadn't happened during the original operation, there was no endoscopic approach. So the cells in the frontal recess hadn't been opened and there was no drainage into the nose. So one of the things, if you're dealing with a mucocele, is about having dependent drainage. And so this mucocele had essentially reaccumulated. And as it had done so, it expanded and it had eroded through the old passageway that the previous surgical approach had used, and therefore created a fistula. So suddenly this stuff was discharging out through the front of the wall of the frontal sinus over the eye. Good. I'm conscious of time though, Hattie. So probably rather than go through all these other examples of cases, I'll probably call it a day there, I guess.